Let's get started. Good afternoon, everyone. I'm delighted to welcome you to the workshop on the intersection of precision medicine and health equity in combating COVID-19. I'm Nishadi Rajapaksa, Program Director at the National Institute on Minority Health and Health Disparities at the National Institutes of Health, and the Director of the NIMHD Transdisciplinary Collaborative Centers on Health Disparities Research Focused on Precision Medicine, and known as the Precision Medicine TCC's program. I would like to extend a very special thank you to Jill Evans from Stanford University for her efforts in planning this workshop, and also would like to acknowledge the contributions of all of the speakers and all of you for joining today. The Precision Medicine TCC program is a consortium of centers that represents a large NIH investment specific to health disparities and precision medicine research. It's a collaboration between three NIH ICs or institutes: the National Institute on Minority Health and Health Disparities, the National Cancer Institute, and the National Human Genome Research Institute. So it's clear that the COVID-19 pandemic has disproportionately impacted minority communities in the United States and has brought existing health disparities into new focus. I hope many of you had a chance to tune in to the plenary earlier today by Dr. Consuelo Wilkins, who alluded to many factors contributing to health disparities in this country, and the role of social determinants of health, political and structural racism that have plagued this nation. And I think the COVID-19 is a great example of these observed racial inequities in the US. So the workshop today will highlight COVID-19 research efforts by the Precision Medicine TCCs, and you will get an opportunity here to hear from all 5 centers funded through this initiative on the important work that's related to COVID-19 research. Next slide. So we have 5 presentations lined up. Now let me welcome and introduce the distinguished panel of speakers. The first presentation will be a joint presentation by Dr. Bonnie Maldonado and Joseph Uracheta of the center, the Stanford Precision Health and Stanford Precision Health for Ethnic and Racial Equity Center. The next presentation will be by Dr. Shanita Hills-Halbert, the Center Director of the Medical University of South Carolina Transdisciplinary Collaborative Center in Precision Medicine and Minority Health, Men's Health. The third presentation by Dr. Stephanie Miller, representing Dr. Consuelo Wilkins of the Precision Medicine and Health Disparities Collaborative, multi-PI collaborative based at Vanderbilt, University of Miami, and Meharry. And the fourth presentation will be a joint presentation by Drs. Minoli Pereira of Northwestern University and Dr. David Meltzer from University of Chicago from the African American Cardiovascular Pharmacogenomics Consortium, also known as ACCOUNT. And our final speaker is Dr. Marcela Nunez-Smith from the Yale Transdisciplinary Collaborative Center for Health Disparities Research Focused on Precision Medicine. She's the co-chair of the President-elect Biden's COVID-19 Advisory Board and the lead of the new White House COVID-19 Equity Task Force. Unfortunately, Dr. Nunez-Smith was unable to join us today, and Dr. Saria Hassan from Emory University will be presenting on her behalf. Next slide. So today's agenda includes a brief introduction to the workshop, which includes a short overview of the Precision Medicine TCC's program, followed by 5 12-minute presentations by the TCC investigators, and a panel discussion at the end. So attendees, you may submit your questions via the chat function, and we hope to address as many questions as we can during the panel discussion. and you may submit questions throughout the presentations. And if there are any particular questions that are designated for a particular speaker, I ask that you please indicate the speaker's name followed by your question. Next slide. So again, the goal of the workshop is to explore the intersection of precision medicine and health equity in addressing COVID-19 in minority communities. We hope to discuss some of the challenges of the COVID-19 pandemic on minority communities, opportunities and successes associated with addressing health equity through a precision medicine lens, emphasizing on the integration of genomics, social determinants of health, healthcare access, tools and interventions. Next slide. The workshop expectations are listed here. I'm not going to go through all of them, but in short, our expectations are to introduce a program with specific focus on precision medicine and health disparities, which is the TCC program, and how this particular program has shifted within the last year to address some of the disparities brought on by the COVID-19 pandemic. And then we will be discussing some of the precision medicine approaches and tools and best practices in the study of COVID-19. And then also finally to generate recommendations for the integration of these disciplines to advance health equity in addressing COVID-19 and future pandemics. So again, your input is going to be quite valuable, and make sure that you submit your comments and questions in the chat box as we move on. Next slide, please. So I'm going to switch gears briefly and describe the genesis of the Precision Medicine TCC program. President Obama unveiled the Precision Medicine Initiative in January of 2015, a bold new initiative to revolutionize medicine and generate the scientific evidence needed to move the concept of precision medicine into everyday clinical practice. So, and precision medicine is defined as an approach for disease prevention, early detection, and treatment that takes into account individual variability in genes, environment, and lifestyle. And for NIMHD, establishing this program focused on health disparities research centers was very important for several reasons, particularly because oftentimes medical advances are not always distributed equitably due to structural or systemic factors that limit the effectiveness of new diagnostic or therapeutic approaches in disadvantaged populations. So while precision medicine holds great promise for improving patient care, its potential for reducing health disparities dependent on a greater understanding of the interplay between biological, behavioral, social, and environmental health risk factors and predictive factors experienced across the life course. And then also the greater inclusion of health disparity populations in research aimed at developing precision medicine interventions. So the NIMHD TCC program is intended to stimulate research that would inform therapies across diverse populations. And we want to achieve with this initiative is to provide opportunities for discovery of experimental research results that would have a direct impact on improving disease burden among health disparity populations. We had, as a first attempt into this new field of research, we had 4 priorities: data integration, population differences in pharmaceutical therapy outcomes, translating pharmacogenomics discoveries to health disparity populations, and then implementation research, trying to understand the barriers for precision medicine in health disparities research. Next slide, please. So we envisioned a national effort with 5 centers expected to collaborate and to develop a network. And the goal was to develop this regional infrastructure for conducting research, implementation, and dissemination activities. Next slide. So the 5 centers have advanced the science of precision medicine and health disparities research in phenomenal ways. And in 2020, the Precision Medicine TCCs published a special supplement on the Journal of Ethnicity and Disease, highlighting research findings from the consortium. Manuscripts focused on a variety of topics and not limited to pharmacogenomics, implementation science, prostate cancer, diabetes, artificial intelligence, etc. So this might be something that is of interest to you, and I encourage you to take a look at this supplement when you get a chance. Next slide, please. So I will end with a photo of the 2018 annual meeting of the Precision Medicine Consortium held at the Stonehouse at the NIH Bethesda campus in 2018, when we all had a chance to interact in person, and it was quite a wonderful meeting. All right, and then with that, I think, next slide, please. I would like to invite our first speaker, Dr. Bonnie Maldonado from Stanford University, for her presentation. Next slide, please. Dr. Maldonado, I think you're muted. Oh, there she is. All right.
Hi, I'm sorry. My internet access just became a bit unstable, so I'm sorry about that. Thank you so much, Nishadi, for introducing the TCCs and all of the work that we've all been able to do together for the last 5 years. I'm going to focus today. My name is Bonnie Maldonado, and I'm the principal investigator here at Stanford University around this important initiative. And I wanted to just give a brief introduction to what our Stanford site has done before I introduce my colleague and partner, Joseph Aracheta, who really did lead the COVID response as part of our Precision Health and Health Disparities Network. So if I can get the next slide, please. So the Stanford program is, our acronym is SPHERE, which is Stanford Precision Health for Ethnic and Racial Diversity Equity. And our SPHERE program, as all of the others are, focuses on identifying genetic and biological markers that we can actually use to do in a very precise manner to try to understand how to reduce diseases, and focusing on racial and ethnic minority populations within our communities, and also engaging not only precision health projects, but community engagement as well, which all of us have felt is critical in moving this research forward. So next slide, please. So the SPHERE research initiatives here at Stanford were 3 initiatives in addition to 5 cores. And each of the initiatives address a knowledge gap that would allow the use of tools of precision health to help us understand and potentially reduce our health disparities that were racially and ethnically identified. So the first project was called IPOP, which I will describe in a bit. And then the second project was Communicating Cancer Genetics. The third project is called Bracelet, Biorepository for American Indian Capacity, Education, Law, Economics, and Technology. And Mr. Aracheta will spend some time speaking about that. Next slide, please. So the IPOP program really used an integrative approach to personalized omics profiling, and we actually used a fairly long-standing racial and ethnic minority cohort of children. So in this particular proposal, we sought to overlay an applied omics technology approach to more effectively prevent, predict, and treat excess weight gain and diabetes risk among low-income Latinx children with overweight and obesity. So this is an extremely deep dive of omics profiling into a group of over 250 children who've been followed already before these 5 years with a several-year program to assess the impact of activities such as dancing and other enjoyable activities for these children on weight reduction. And the IPOP sought to see if there could be biological markers that could predict or even predict and develop a better assessment of what the impact of weight loss and weight gain was on these children's overall metabolic profiles. And this included genotyping, methylation sequencing, RNA sequencing, and metabolomics. And those studies those data were collected, but over the last few years, we've continued to analyze data and identify biomarkers. Next slide, please. Our second project, Communicating Cancer Genetics, really looked at a more integrated function around looking at how genomics and precision medicine are perceived by different cultural groups. So we understand that we have the potential to advance our understanding of culturally sensitive approaches to communicating precision health and what that really means to our patients and families. And one of the ways we did that was we enrolled 619 Latinx, Asian, and Caucasian women to understand the quality and content of communication between clinicians and their patients in describing genetic cancer risk information. So that was done by videotaping and then assessing the correspondence between the recommendations of the doctors and the subsequent actions of the family. So this is really about on the ground translation of the genomic tools that we use into a culturally sensitive approach. What works best in communicating this information to patients and their families, and what are the clinical outcomes of these communication schema. So the next slide, please. And so finally, just to show you what we've done so far overall, before I go on to Mr. Aracheta, again, the overarching theme, as always, has been health equity. So we have a fairly very well involved community advisory board made up of 10 members representing 5 underserved populations. And we meet quarterly, participating in projects. Actually, we put out a small call to have each of the community advisory groups get together with their community so that they can actually build on local pilot projects that affect their community members. And that is our attempt to really get additional community engagement. We also have, in the last year, 8 funded COVID-19 projects. 4 of them are population-based. All of them involve racial and ethnic minorities, as well as majority populations. And finally, more recently, in fact, tomorrow will be our inaugural Health Equity Action Leadership Network that we've developed in partnership with Sphere in order to try to bring our health disparities faculty researchers together across Stanford School of Medicine and start to address health equity issues in a collaborative manner. So clearly Sphere has been very helpful. TCC has really helped us focus on health equity. And to that end, I would like to introduce Mr. Aracheta, who is going to talk about the third project and really how that led to a COVID-specific intervention that will have an important impact in his community and hopefully other communities around the country. So Joe, I'll hand it off to you. Thank you so much.
Hi, my name's Joseph Aracheta. I am the Vice President and the Executive Director of the Native Biodata Consortium, which was built alongside a Stanford project on rheumatoid arthritis and autoimmune diseases in tribes from the Northern Plains. We took the opportunity working with Sphere to create the policy and physical infrastructure of the Native Biodata Consortium around samples that have been collected locally. And we've did that for the last 5 years, and we were able to get our tribal approval in May of 2018 and our nonprofit 501c3 status in November of 2018. And when the COVID epidemic happened and the money was having trouble getting to communities like rural South Dakota tribal communities, we took the opportunity to write a grant with Stanford to add resources to this community here. And so if you don't know, a lot of tribes suffered early on for lack of testing and a lack of contact tracing. And here in South Dakota, they didn't really start getting testing, which was minimal testing, until about May of last year. And then they started getting a lot more testing kits, mostly the Abbott kit, around September of last year. And then the contact tracing didn't really start in earnest until about November, which is when we had our peak of last year. And what we are doing is trying to make sure that other types of data are collected, specifically pre-existing conditions and pre-existing immune profiles, which are likely to be very different for Native American groups. And then both natural infection and vaccine individuals, their post-genetic profiles, I mean, not genetic, their post-immune profiles, along with any sort of long-term or short-term lasting of antibody response in either case. Next slide. So part of what's good about RADx for our community is the ability to bring quickly cutting edge technologies to these rural communities in South Dakota, specifically for the questions that I mentioned. There's likely to be a lot of immune differences pre and post infection, and making sure that the specificity and sensitivity of that testing is accurate for these communities is also something that hasn't been done in any kind of comprehensive way, which would be partly due to the different technologies that are mixed here for the emergency authorization, but also because of the unique ethnic profile of Native Americans. So we want to be able to validate and bring things faster and cheaper to this community. Next slide. So we will be using the gold standard and making sure that the sensitivity and specificity of that test is accurate for this community. Like I said, a lot of what the Indian Health Services provided was the Abbott testing kit, and then that gets verified by the PCR testing about 90 minutes away from here. And we will be developing a state-of-the-art lab with CLIA certification here on the reservation, so that if this happens again for some other pandemic or continuing pandemic, we won't be reliant on other labs for certified test results. And then in addition to making sure that the tools and the tests work, we'll be building local capacity and a way to disseminate the information both to tribal public health and to community members in a secure and private manner. Thank you. This slide. This is an ongoing thing with the biorepository, trying to get most of the work that's done here either in the COVID space or the omics, genomic space locally, so the samples and the data will be held here, hopefully to leverage the richness of that data for implementation locally. So the part of the problem is that the samples and the data end up going somewhere else, and the dissemination and translation for actually implemented solutions here in tribal communities makes things very slow and sometimes a neglected process. So by building facilities here, we hope to build more chance for improvement of quality of life and health here. Thank you.
So good afternoon. My name is Shanita Hughes-Halbert. I'm the principal investigator at the Transdisciplinary Collaborative Center in Precision Medicine and Minority Men's Health at the Medical University of South Carolina. I'm really pleased to talk with you about social determinants of minority health during COVID-19. And what I wanted to do today was just illustrate our conceptual framework and our key measures and how that can be used to structure our thought process, measures, and research initiatives around COVID-19. Next slide, please. So social determinants, which are shown here, include the characteristics that define where and how individuals live and how we obtain health care. There's been growing consensus and interest in understanding the role that social determinants play in minority health and health outcomes. And they've really grown in terms of their importance and significance during COVID-19. Next slide. We here at MUSC have been focused on social determinants of health since the inception of our center. And as you can see here, our research projects and our cores focus on conducting translational research to understand the ways in which biological, social, psychological, and clinical factors interact to lead to disparities in health and healthcare outcomes, particularly among minority men. This is, next slide, please. Really important because when we think about COVID-19, you know, a question that has emerged for us is, well, why should we care about social determinants of health during COVID? So first, as I've already said, social determinants influence where and how we live and how we access healthcare, but it also has grown, and we see more and more in the empirical space and the news media that social determinants such as race and ethnicity and where and how people live influence and contribute to risk of infection and morbidity and mortality following COVID-19 infection. It also influences and has impact on the risk mitigation strategies and an individual's ability to be socially distanced or not socially distanced in and outside of one's community. And then importantly, it influences access to healthcare and long-term management. And as you can see here, there's been several commentaries published over the past year, which have really focused on structural racism, social risk factors, and COVID-19. And what we're really understanding is how these factors converge and lead to poorer outcomes among African Americans, as well as other medically underserved groups. Next slide. So the MUSC TCC has been working within this space for a number of years, and our work was really prompted by the social stressors that African American men in particular face. And as we were conceptualizing our center, one of the things that we witnessed as I witnessed as a resident here in Charleston, South Carolina, was, and what we've seen more and more throughout the country, is just the extreme social stressors that African American men experience and result in police killings and other types of violence. We know that social and psychological stressors impact biological functioning and processes that are involved in the initiation of disease and the progression of disease. What we were interested in doing, and what we've been doing over the past 5 years, is working to understand the nature and distribution and impact of allostatic load, which is a marker of how much social and psychological stressors impact biological functioning. Our work in allostatic load builds upon the tremendous previous evidence base about racial disparities in allostatic load. But as we were reviewing this literature and thinking about how it applied to where we are now and today, that there's been relatively limited attention to minorities' men's health. And that as we thought about proposing or exploring allostatic load as a marker of stress and stress responses and stress reactivity, that we needed to have a better understanding of its impact on disease processes and outcomes. Next slide. So our primary question for the center, which I think is highly relevant to COVID-19, is how does psychosocial stress influence cellular stress responses? And as you can see depicted on this slide, each of our projects, our primary translational projects, has a focus on understanding stress responses from the perspective of a laboratory stressor, from the perspective of stress responses as measured at the time of surgery in the case of men undergoing radical prostatectomy for prostate cancer treatment. And then thirdly, how allostatic load and stress responses inform the response to treatment for early stage prostate cancer. And just as South Carolina has proven to be, I think, an important context for understanding precision medicine tools and strategies, it's also, I think, an important context and geographic area for understanding the ways in which COVID-19 is manifested, the ways in which individuals respond to risk mitigation strategies, and the ways in which individuals respond to vaccination initiatives. Next slide. So how do we do this? So as you can see here, we've created, I think, several important strategies for understanding the social context in which men are living, working, and obtaining healthcare. This is shown, we use a standard social determinant survey that's used to, and these, I think these variables are highly relevant to COVID-19 in that they define the nature and distribution of stressors related to financial hardship, comorbid conditions, and living within a geographic area that has high structural deprivation. Next slide. A particular focus of our work has been on understanding social connections as manifested through social isolation and social loneliness. And these social connections have emerged as an important priority that's particularly relevant for COVID-19 in that, one, as we think about it on a population level, that this important commentary that is shown here, quote, that Black Americans were forced into social distancing long before coronavirus as a result of structural and systemic racism. So our focus has been on understanding the ways in which social isolation is experienced and loneliness is experienced by men as they are sort of living within their disease context of prostate cancer diagnosis or diagnosis of other other acute and chronic diseases. And how, now as we move forward, it's an important context and strong construct for measuring the impact and outcomes of risk mitigation strategies and sort of all the collective response that we're experiencing as a result of risk mitigation strategies. Next slide. I wanted to share with you the approach that we've taken. So we have used a multi-level approach to understand social connections under the leadership of a postdoctoral fellow, Awole Badatunde. And what we've been able to do is to develop and apply tools to assess social isolation at a community level or social factors at a community level using variables such as the social deprivation index at an individual level, which are shown here. And then also developing tools to identify patients who demonstrate and have documentation of social isolation in their electronic health record using natural language processing tools. Next slide. So I've mentioned that that we've been interested in allostatic load among minority men because it reflects the ability of an individual's physiological systems to adjust to stressors and challenges that they're experiencing. And collectively as a country, as we've all experienced some level of stress as a result of COVID-19. allostatic, and for that reason, allostatic load is relevant because it's a life-threatening condition, a life-threatening stressor that really has impacted us all, but particularly among those who have COVID-19 infection, particularly those who have severe disease. So allostatic load, I think, is an important variable and marker of physiological stress responses that can be obtained using vital statistics recorded in the electronic health record. It can be obtained using prospective laboratory assessments, and it can also be measured by self-report using psychological, community, and environmental level data. One of the reasons why we were interested in exploring allostatic load is because it can be measured in multiple ways using multiple strategies, and it is accessible to community healthcare systems which may not have the latest and greatest technology for genomic research, but all healthcare systems collect some level of vital statistics that are relevant for allostatic load. What I wanted to show you in the next slide is the ways in which we're conceptualizing it, first by looking at racial differences in allostatic load and including clinical variables that are relevant, in this case, to prostate cancer risk and outcomes. So you can see that there are significant racial differences in allostatic load between African American and white men who've been diagnosed with early stage or locally advanced prostate cancer. But importantly, as shown in the next slide, when we look at these variables within the context of a social determinants model, that the effect of race is mitigated, but it's really there's social isolation has a significant independent association with allostatic load. And so it raises for us, again, the importance of understanding both the clinical parameters and determinants of COVID-19 risk and outcomes, but also understanding COVID-19 risk and outcomes within the context of the social context and social risk factors. Next slide. So as we think about the types of data and systems that should be prioritized as we during and after the COVID-19 pandemic, social determinants, I think, is a really important priority. We've used the framework that was established with funding from the National Institute on Minority Health and Health Disparities and the National Cancer Institute to develop a really important socially informed conceptual model of health and healthcare outcomes that are relevant to the populations that are disproportionately affected by COVID-19. And so we would want to leave, sort of think about our work as we've applied for one of the post-acute long-term sequelae of COVID-19. We've used this framework in our application with a high priority of understanding social determinants and stress responses and stress reactivity among individuals who are at risk for long-term COVID. And so as I conclude my remarks, I'd like to just acknowledge and thank the collaborators in our center in the next slide, who have really contributed significant amount to our thought process and work as we've implemented the center and conducted our research. And as we move forward in the next phase of our work together to continue to advance health equity among minority men. Thank you.
Hi, good afternoon, everybody. I'm Stephanie Miller-Hughes. I'm one of the 4 co-PIs of our Precision Medicine Health Disparities Collaborative, or PMHGC. And I'm delighted to be sharing some of our work, particularly around targeted strategies to address the COVID pandemic in Tennessee and Florida. So these are 2 states where racial and ethnic minorities are indeed carrying some of the heaviest burdens across the United States. So kind of given our collective pre-COVID experience in health disparity mitigation efforts, we've been able to apply some key aspects of what we learned to our COVID work, and this includes some very targeted approaches to address health equity gaps, which is not unlike some of the goals of precision medicine, and the need for stakeholder involvement throughout the process, as others have mentioned. So these will be some kind of reoccurring themes you'll hear throughout what I'll share today. So next slide, please. So here is our team on the left of this slide. You'll see that our PMHGC has brought together a group of researchers across Meharry Medical College, the University of Miami, Vanderbilt University Medical Center. This includes the transdisciplinary team of co-PIs and cores. As stakeholder engagement is critically important to our work, as depicted in the figure on the right. There you'll see kind of two distinct advisory boards providing overall guidance and feedback on our activities and research projects. And so what I'd like to do now is to share with you some of the COVID-related work of each of our institutions that we've been leading. So you'll have to go with me a little bit across the Southeast. We'll go back and forth a little bit. So just buckle in. So I'll start here with Meharry, which is my home institution in Nashville, Tennessee. So relative to testing, for about a year now, Meharry has led operations of Nashville's 3 testing sites. So our president at Meharry, Dr. Hildreth, has been a very early advocate of making sure that the sites are situated in places where racial and ethnic minorities, particularly African Americans and Hispanics, live their lives. So this is a targeted approach. So the sites are still up and running today. Approximately 300,000 tests have been administered, and the greatest number of tests have been indeed among African Americans and Hispanic Americans have indeed been at the locations that were strategically placed in areas most accessible to them. So if you move up to the middle panel, Meharry has also been involved in vaccine trials, including for Novavax and currently Moderna. So the top picture in the middle is really of an evening session that our trial investigators had with community members to share trial information and really to just listen. And so one of the investigators shared that this more personal approach needs to remain a part of all of our recruitment strategies, because these decisions about enrollment in trials are really personal. But also, I think a point is what some of the more personal conversations reveal is information that we can use in larger recruitment efforts. For example, the bottom picture in the middle is one of our recruitment flyers, which addresses some misinformation that we heard during some of these early conversations around the vaccines themselves causing COVID infections. So we included that on the flyer. So the pictures on the right kind of highlight our efforts in the vaccine rollout. So the picture at the top is one of our sites at Meharry that we opened up doors on a Saturday morning to provide vaccinations for those 75 years and older. We also have our president, who now is serving on the White House COVID-19 task force. And so these are just some examples of the activities happening at Meharry. Next slide, please. So here is just specifically some research happening here at Meharry. So to date, we've received about $8 million in COVID-related research funding. And the 2 projects I'm highlighting here are part of, more recently funded as part of our RCMI program in Health Disparities. And so for the first one on the left, pre-COVID, breastfeeding rates were lower among African-American women. And now that the breastfeeding guidelines have changed to include some additional safeguards to protect against infant COVID-19 infections, there's a concern that these rates could worsen. So this project is really focused on developing interventions to promote kind of adoption and maintenance of these new guidelines. So importantly here, this is being done with relevant stakeholders, including breastfeeding moms and providers. So the second project on the right is also focusing on a pre-COVID problem, but that is more systemic in nature, and that's racial and ethnic discrimination. So in this case is specifically related to how discrimination is influencing access to COVID-19 testing. So in this project, researchers are working with YWCAs that provide services for predominantly racial and ethnic minority women and their families. And so while both of these studies really are very COVID specific, they really highlight the importance of recognizing the potential for a pandemic and just crisis in general to exacerbate disparities, and that some of the things we're doing pre-pandemic may not work anymore. So we may need to go back and take a look and examine some new approaches. And the other point I want to make here is relative to the second project, is that we cannot shy away from conducting research that can kind of unearth the degree and manner by which racial discrimination influences access to service. In this case, particularly, life-saving preventive services. So next slide, please. So on to sunny University of Miami. So Dr. Alvin Carrasquillo leads our consortium core for the PMHGC, and I'm delighted to share some of the work that he's been leading there. So kind of at the very outset, relative to clinical trial enrollment, his mantra was that, we need to raise our sights higher when it comes to recruitment of African Americans and Latinos into these trials. And so in this case, the numbers are worth 1,000 words. So if we look at both the left and right panels, it's very clear that recruitment and enrollment of these two groups was much better than what occurred nationally for both the Johnson & Johnson and Moderna trials. So if we think about what worked for both trials, the most impactful strategies are listed here, but in essence, it was the targeted approaches that were used, including ethnic media, leveraging partnerships with community stakeholders, such as community health workers and community-based organizations. And so, what didn't work for both trials? And so kind of the sponsor level advertisement and recruitment methods did not work. So, talking to Alvin about this, he was like, Stephanie, it was really just our very targeted grassroots efforts that really helped us reach the goals that we did. So, hats off to our team at Miami for this progress in recruitment. So next slide, please. So I know everyone's like, well, what did they do? Well, here's just a little bit of what they did. And, I think this other slides show that it paid off. So the red text is just to highlight the different groups or the focus of some of the work, but also take note of some of the content. For instance, the first presentation is simply titled Get the Answers. And this is particularly important because people were and are definitely still information seeking. So there needs to be a place for credible information. The third presentation is focused on COVID vaccine confidence. And so note the use of confidence and not hesitance, which often carries a negative connotation. So here again, paying attention to what we're hearing and targeting and tailoring our efforts accordingly. Also note the different stakeholder groups for these presentations such as Legislative Black Caucus and American Muslim health professionals. So relative to media on the right of the slide, they did both national and local efforts. So really some Herculean efforts here to get those enrollment results for the University of Miami. So next slide, please. Okay, we're switching states again. We're back in Tennessee. So moving on to Vanderbilt University Medical Center. So for those that attended the plenary session, you heard Dr. Wilkins mentions this work, but briefly here, she is leading this work as part of a health equity working group. And last year they began disaggregating COVID-related data by race, ethnicity, language, and zip code. And the table and figure here, just examples of some of the data that was generated and reviewed daily. But importantly, some of the data showed, as some of you may have heard, was that those with limited English proficiency had a more than 4-fold higher positivity rate than those that were English proficient, and that the highest number of cases were in 2 zip codes where more than 30% of the residents had limited English proficiency and adjusted household incomes lower than the county average. And so pay attention to what they did with this information. So data is important, but what they did was, they alerted local and state health departments. They created multilingual resources. They assessed interpreter capacity. They engaged community organizations. So, the take-home message here is, we can't address problems we don't know about. So the data is critical, and we need to engage, different types of stakeholders in developing solutions. So next slide, please. So I now like to highlight a kind of a telehealth equity project led by Dr. Sherry Barkin. She's a pediatrician at Vanderbilt University Medical Center. So the pandemic brought along with it a lot of things. And one of them was an urgent need for telehealth, but it also quickly illuminated some gaps relative to what we know about service delivery from an equity standpoint. So in aim 1 of this project, Dr. Barker and her team are using a survey to kind of assess the relationship between telehealth uptake and factors such as language, race, ethnicity, and impact of COVID. And so the table on the left just kind of shows where they are in this work to date. And so this data will partially inform the second aim, which is really focused on redesigning standard telehealth approaches. And so to date, using community engagement studios, which is a construction method to get stakeholder input on research as well as quality improvement projects, families have provided input. The results are actually currently being used to redesign the telehealth approaches. And so the next step is to assess the feasibility and acceptability of the redesign among pediatric families. So next slide, please. So on my final two slides, I'd just like to share some work of the NIH-supported Community Engaged Alliance Against COVID, or SEAL, which many of you have probably heard about. So these funds were awarded to 11 states for which the COVID-19 burden was highest among racial and ethnic minorities. The Meharry-led Tennessee SEAL includes 3 grand regions, West, Central, and East Tennessee, with community and academic partners in each region. You can see that on the left. The arrows just highlight the participation of 2 of our PMHGC institutions, of course, Meharry and Vanderbilt University Medical Center. Dr. Wilkins and I serve as co-PIs of the Central Tennessee region. And so the aims are really focused on identifying and developing strategies to address COVID, among those populations listed at the bottom of the slide. And so the progress to date includes getting community input on a research project. Again, there's that importance of stakeholder engagement to test the efficacy of a community health worker-led intervention related to outcomes like COVID prevention, vaccine readiness, and treatment. It also includes some tailored messaging campaigns and webinars. So next slide, please. Okay, back to the sun, back to Florida. So the University of Miami also received a SEAL award. That's being led by Dr. Alvin Carrasquillo, who I mentioned previously. And so they too are engaging various community partners, and their aims are focused on identifying barriers to participation in research among those populations listed at the bottom. And they're going to use that to develop targeted solutions that will inform both health promotion practices and participation in trials. And so you'll just note some of their engagement to date, including mobilizing 460 outreach workers and making more than 4,000 direct person-to-person contacts. So next slide, please. So I will end our travels here, but I did want to acknowledge our team, of which there are many, and across our 3 institutions. But this is us in 2019 in all of our no mask wearing, non-social distancing glory. So on behalf of this team, thanks for the opportunity to share our work.
Next slide, please. Thank you for the opportunity to present it on ACCOUNT, which is the TCC that I co-PI with David Meltzer at the University of Chicago. And we're going to talk about how we went from pharmacogenomics to COVID-19. Next slide, please. So ACCOUNT, what our TCC was originally tasked with doing, and what ACCOUNT stands for, is the African American Cardiovascular Pharmacogenomics Consortium. And this consortium is built around many institutions, 3 in Chicago, 3 in Washington, D.C., around the idea to accelerate the discovery and translation of pharmacogenomic findings in African Americans. And this graphic shows you that the 2 major projects are our discovery project and our translation project, but I'll discuss that in a minute. I'll give you a little bit of the lay of the rest of the consortium's work, which has been really quite vast and has grown in the years we have been funded. So one of our major objectives was to increase the amount of omics, genomics, transcriptomics, all of these big data sets in African Americans, which is really missing from the genomic landscape and has been missing and underrepresented for quite some time. And so we built the ACCOUNT Data Commons, in which all of the data we're collecting would be deposited. And this has built the largest data set for African Americans with linked genomic, transcriptomic, and clinical data. And so we built a platform in this core in which we would be able to share this data in HIPAA compliant manner, as well as being de-identified. So others in the research and scientific spheres could use this data and build upon what we have built in ACCOUNT. We also had a lot of engagement from the community. We have a community stakeholder advisory board. This board is made up of people in all of the institutions that are part of ACCOUNT, but also has representation from the American Heart Association, the Association of Black Cardiologists, as well as the Alpha Kappa Alpha sorority. And they give us support in study design as well as our community-based pilot projects. These pilot projects have really been a key focus in account, and they've helped produce resources for the education of providers, whether that's clinicians or other types of medical providers, and patients on African American pharmacogenomics. And they've been highly successful in reaching into the community and helping people understand the benefits of what pharmacogenomics can do, and also the limitations of what it cannot do. Next slide. So I'd just like to spend a little bit of time talking about our two cohorts, the discovery cohort and the translation cohort. These were our two biggest research efforts. The discovery cohort was recruiting patients at 5 different institutions, all of them African American, that were either on anticoagulant or antiplatelet therapy. Our focus was always cardiovascular, given the disparities in cardiovascular disease between populations. And we had recruited many different cohorts into this discovery this larger discovery cohort with paired genomic, transcriptomic, plasma data, many different types of biological samples, in hopes of identifying new genetic or population-specific genetic variants that may be predictive of drug response. Our translational project created a custom clinical decision support tool that was implemented within our electronic health record. This tool did preemptive genotyping for African Americans and delivered the pharmacogenomic relevant findings to their physicians at the time of encounter. So it's a way to give pharmacogenomic information to physicians at the time that it would be most impactful. And we were very thoughtful in including things that were very specific for African Americans as a population. So things that would affect African Americans in their response to medication that have been well studied and documented and could be included in helping them tailor their therapy. At the time in 2020, we were actively recruiting in both of these cohorts and starting our preliminary analysis when COVID-19 hit. And this resulted in a halt of all our recruitment activity in April of 2020. At this point, we really wanted to think about how could we contribute to COVID-19, and especially given the disparities seen in morbidity and mortality for COVID-19 in African Americans. So we pooled the 1,300 African-American patients we had gained data for across discovery and translational cohort and pivoted to thinking about COVID-19 susceptibility and phenotypes and if genomics played a role in susceptibility. We also, because of our interest in cardiovascular disease, were very interested in the coagulopathy phenotypes associated with COVID. So these are clotting disorders that happen after COVID infection and increase the morbidity and mortality of COVID, but were happening at a higher rate in African Americans. And that's true for clotting diseases in general, but this was specifically true for COVID-19. We also had a specific interest in vitamin D, and David Meltzer will discuss that in just one moment. And I just have here a small table showing you after we pivoted and collected all this data, how many people we had that were either tested COVID positive or were controls, meaning that they did not test COVID positive or were not tested, as well as the number of hospitalizations and COVID-related deaths that were found in our cohort. Because our cohort was still relatively small for a genome-wide study, we joined a larger international effort. Next slide, please. And this effort included 58 other cohorts. And I just want to take your attention in this. These are 2 figures from the paper. The paper is currently under peer review, but is freely available in medRxiv, and you can see the link here. If you would just look at the ethnicity breakdown, Of these 58 studies, you can see that a vast majority were from European nations or European ethnic groups. And so there were over 2 million people that participated in this global effort. And there were only 6 studies that had African ancestry populations. So we were one of those 6 studies that contributed data to this larger effort. And I just like to highlight a little bit of our findings. So for those unfamiliar with genomic studies, on the left-hand side is a Manhattan plot, which maps out every genetic variant tested for either COVID hospitalization or testing positive for COVID-19 or COVID susceptibility. And on the y-axis is the p-value, the negative log p-value, so that the higher up on the y-axis, the more significant these genetic variants are. And highlighted in this figure, the yellow are those that are specifically linked to hospitalization, and the teal color are specifically linked to susceptibility. And just some of the interesting pieces we found was that the CXCR6 gene, or variants very close to that gene, were linked to COVID-19 hospitalization. And why that's interesting is that CXCR6 is a chemokine receptor and this family of receptors have been linked to susceptibility to HIV as well, and had a lot of media around that finding. So here again, we're seeing the same finding with COVID-19 or a similar finding. The other very interesting finding was that we saw that the ABO blood group or blood type, the locus that determines the blood type of people, is significantly associated with susceptibility. That's on chromosome 9. And this is not a new observation. It had been observed that people with type A blood type were more susceptible to COVID. So here we are seeing the genetic link to that. Also, I'd like to say this was a really collaborative effort, and all of the data that you see that is in this paper is actually publicly available. And I have put the website here, covid19hg.org, where you can explore any of the genetic findings. You can see subset analysis, and you can actually download the summary statistics or the association results yourself if that is of interest. Next slide, please. Here, I'd like to switch to David Meltzer's interest in vitamin D and COVID-19.
Great, thanks, Manoli. I think as people are probably familiar, there's a long literature showing that vitamin D enhances both innate and adaptive immunity. And we know also that it's an effective immunomodulator, which in the context of COVID may be very important in preventing the hyperinflammatory response that we know is so much of the problem with COVID-19. What got me interested in this area was discovery of a study that had been published actually a few years ago that was a meta-analysis by Adrienne Martineau, which showed that vitamin D supplementation decreases viral respiratory tract infections by an amazing 70% in randomized trials of persons with vitamin D deficiency. And we know that vitamin D deficiency is especially common in African Americans. And having seen this article and being at the University of Chicago, where we had a largely African-American patient population presenting with COVID early in the epidemic, I thought, boy, we could actually test this by going into our electronic health records and looking to see whether people who were vitamin D deficient were more likely to test positive for COVID. So we did that, and we discovered that vitamin D deficiency was associated with a 77% increased risk of testing positive for COVID-19, controlling for a whole range of comorbidities. We did an initial analysis, which we put in medRxiv very early, actually in May. I think we were the first people out with this association, and then published it in JAMA Network Open in September. And then just about a week ago, we published a follow-up study with now 3,000 patients, which showed that this increased risk with vitamin D deficiency was particularly focused in African Americans. Interestingly showed that there was an increase in risk when you drop even to levels of 30 to 40 nanogram per milliliter, which is considered sufficient by most standards, compared to levels of 40 nanograms per milliliter above. So it seems that protection among African Americans with this, at least association with vitamin D, is dependent on higher levels. I will say that these are observational studies, but randomized studies are beginning to show some evidence that vitamin D can be important. There was a Spanish study which gave multiple doses of activated vitamin D to patients hospitalized with COVID and showed a 90% decrease in ICU use. That study has been criticized based on some imbalances between arms, but a careful analysis suggests it's unlikely that even those explain it. There was also a Brazilian study published in JAMA just a few weeks ago. This was a slightly different therapeutic approach. They gave just a bolus of vitamin D and no follow-up doses. And they found no decrease in hospital length of stay, but they found a trend towards lower mechanical ventilation and lower ICU use. Interestingly, that trend was not significant, in fact, smaller in people with low vitamin D levels. But when you back out of the table, and we did this ourselves in a comment that's on the JAMA website, we found that there was actually a 50% decrease in mechanical ventilation and ICU use, with a p-value of about 0.05 in the higher vitamin D group, which was almost certainly in this Brazilian population, individuals who were white. And then no real effect in this lower vitamin D group, which is likely African origin. And the reason we think that this may be the case is that there are known differences between African Americans and whites in a variety of aspects of vitamin D metabolism, not just production, but vitamin D storage and also destruction. And it's likely that Caucasians have lower affinity vitamin D binding proteins that more easily release it in circumstances when it's been given in a large dose, for example, over a long summer or in a bolus dose, as was done in this study. And that may be why the vitamin D worked in that population, but didn't work in the African American population. And the implication is very clear, which is that daily doses may be particularly efficacious, particularly in African Americans. We're now doing 3 funded clinical studies to look at COVID risk and outcomes. NCATS funded us to do a randomized trial of low versus moderate versus high dose vitamin D, which is with in-person recruitment. We're also doing a second study, which is community-based and done on the internet, looking at just low versus moderate dose vitamin D, and that actually can now recruit nationally. And then we're doing a quasi-randomized study with medically complex patients to look at sort of optimal medical management of vitamin D for COVID prevention in people with comorbidities. There's some additional work, but I'll turn back to Manoli to talk about what's coming next.
Thank you. So in our future directions, I think a really important piece of what we do is to take deep dives specifically in African ancestry populations. So we plan to do an African specific analysis in collaboration with other consortia, should we be able to share this data, to look for both susceptibility, hospitalization, and coagulopathies within genetic risk for these within people who have been infected with COVID-19. And I'd like to say this is specifically important because many studies like the international effort, which include many different populations, but are predominantly of European ancestry, can easily wash out signals that are African ancestry specific. So people who have an African background may not be well represented in these trials. And so you need to have dedicated studies that study specifically African ancestry patients. We collected plasma from all of our patients, so there are potentials for metabolomic work from our banked plasma, as well as transcriptomic studies. Both of these are incredibly interesting because the coagulopathies were thought to be imbalances in both the plasma proteome and potentially the transcriptome, even at baseline. And we've already seen that these differences, or there's a variability in several clotting related proteins that may contribute to the increased risk we see for clotting in African Americans. And as David was talking about his vitamin D work, he currently has a proposal under review to examine vitamin D binding proteins and the genetics of what people talk about is long COVID, or the persisting symptoms of COVID after COVID infection, specifically in African Americans. Next slide, please. So with that, I'd just like to thank all of the people that work in Account, and this was our last in-person annual meeting for Account in 2019. Again, all maskless and happy. It has been a tremendous effort, and there are many, many other contributions that I couldn't discuss here, but we'd like to also thank our funder, the National Institute for Minority Health and Health Disparities, for making this work possible.
Hello, good afternoon, everyone, and thank you for the opportunity. My name is Sadia Hassan. I've had the privilege of serving as Deputy Director for the Yale Precision Medicine Center. The lead PI of that center is Dr. Marcela Nunez-Smith, who sends her sincere apologies for not being able to make it today. So it's on her behalf that today I'll be presenting on community engaged research on COVID-19 testing in the US territories. Next slide. So as many of you know, the US territories is home to almost 5 million residents who represent racial and ethnic minorities, but that is also home to rich cultural and linguistic diversity, as you see in some of these images at the bottom of the slide. Our focus is mainly on the Caribbean US territories, Puerto Rico and the US Virgin Islands, but a reminder of the 3 Pacific territories of Guam, Northern Marianas, and American Samoa. Next slide, please. So the Eastern Caribbean Health Outcomes Research Network, known as ECHORN, and the Yale Transdisciplinary Collaborative Center for Health Disparities Research Focused on Precision Medicine, the Yale TCC, are truly a unique collaboration between the islands of Puerto Rico, the US Virgin Islands, Barbados, Trinidad and Tobago, with the goal of addressing chronic disease disparities, both at the territorial level, focused on the US territories, but also, given our knowledge of the large Caribbean population here in the mainland US, also US-based disparities. The addition of Trinidad and Barbados to our collaboration allows us to bring in that Caribbean context that is so important in understanding some of these disparities. So you'll see the objective listed here is really developing a consortium of academic, community, and policy partners to advance actionable scholarship on chronic disease in Caribbean descent populations, which truly highlights the importance of our consortium of stakeholders and our collaboration with our stakeholders in everything that we do. Next slide, please. So our leadership team is leaders within the US Virgin Islands institution, University of Puerto Rico, the University of West Indies in Barbados and Trinidad and Tobago, and then the Yale School of Medicine. But also part of our leadership team is a leadership team for our consortium of stakeholders, led at the academic side by Dr. Laverne Raxter, the past president of the University of the Virgin Islands, and representing civil society, Professor Sir Trevor Hassel, who's president of the largest civil society organization in the Caribbean, the Healthy Caribbean Coalition. So again, a testament to how we work very closely together in moving the ECHORN agenda forward. Next slide, please. Perhaps our seminal project, which I'll highlight here, is our intergenerational cohort study, which is truly a unique cohort within the Caribbean. We currently have 3,000 community dwelling adults as part of this cohort, allowing us a unique opportunity to understand risk factors and early predictors of chronic disease in this population of adults in the Eastern Caribbean. And now, as we bring individuals back for follow-up with an eye towards precision medicine, we are elucidating phenotypes of hypertension through our hypertension subproject and identifying novel biomarkers that it can improve our ability to predict type 2 diabetes among individuals at high risk through our diabetes subproject. And additionally, now with a new R01 grant from the National Heart, Lung, and Blood Institute, we're really forming an intergenerational cohort, bringing in the children and the grandchildren of the adults in our cohort study to now understand intergenerational factors that contribute to chronic disease. And this study has a specific focus on sleep and the contribution of sleep towards those risk factors. Next slide, please. And it's really thanks to our amazing team of stakeholders, community members, fellows, faculty, and staff that you see the accomplishments which we've listed here, both from a dissemination standpoint, training standpoint, and collaborative learning. And while you read the quote from one of our pilot project investigators, I will say that the Ekhorn and Yale TCC was actually a recipient of the ACTS Team Science Award in 2019, really a testament to how amazing this collaboration truly is. Next slide, please. But as experienced by all of you here, in the midst of the nitty-gritty and the day-to-day of all of that work, we were all hit by COVID-19, and the US territories were unfortunately not immune to that. And so as you'll see here, experienced both in Puerto Rico and the US Virgin Islands, a significant number of cases for the island population. But importantly, in the more recent months, we have not seen a significant decline in cases that we've seen in the mainland US, with truly a stagnation in the number of cases of COVID-19 that is truly worrisome. And this is, of course, in the setting of the ongoing territorial health disparities, which really were the impetus for all of our work in the Caribbean. And it dates back to 2011 with Dr. Marcela Nunez-Smith's seminal paper highlighting the significant disparities looking at 30-day mortality for hospitalized patients between the US territories and the mainland US. So you have COVID-19 on top of that baseline disparity. And so what could we do as part of Ekhorn and the Yale TCC to help address that? Next slide, please. And so we're truly thankful to NIMHD for the opportunity to compete and be awarded this RADx Up supplement, which allows us to really increase the capacity within the US territories to address the COVID-19 pandemic. So you'll see the two aims of our project listed here, enhancing testing strategies through community engagement and ensuring cultural responsiveness, with aim two really assessing the diffusion and uptake of approved testing technologies. Next slide. Really the focus of the RADx Up collaboration is on federally qualified health centers, which many of you know are truly the health centers that provide care for the most vulnerable within the US mainland, but also within the US territories. And so we're truly really fortunate to be able to collaborate with Health ProMed, which is one of the largest federally qualified health centers of the 22 in Puerto Rico. And then there are only two FQHCs in the US Virgin Islands, Frederiksted and St. Croix, and St. Thomas East End Medical Center in the US Virgin Islands. In addition to the FQHCs, you see Puerto Rico Science Research Trust there, which has had a long-standing relationship with community-based organizations in Puerto Rico, but also importantly, the community-based organizations who we're working very closely with, Catholic Charities and LACE in Puerto Rico. Next slide, please. And so what our proposed model and what we're trying to do here is really create this or enhance the link and the collaboration between our community-based organization partners and the federally qualified health centers, with the goal of doing two things. One, increasing the capacity of the FQHCs to actually conduct more testing. So new machines, more testing supplies, more human resources, but importantly, working with the community-based organizations to increase our outreach into these communities to increase their demand for testing. And this has actually become ever more so important now, as we see the demand for testing start to decline, as people become more complacent, their guard is coming down, they see the vaccinations rolling up. And as we've recently seen just in the last few days, this has resulted in an uptick in our cases, partly due to the new strains. So testing today is even more important, and using our community-based organizations to reach out to these individuals to really reiterate the importance of testing is even more critical. But in addition to increasing the outreach, we've realized the importance of supporting individuals who test positive. So our model really emphasizes the importance of really improving the wellness and supporting the wellness of individuals who test positive, as you see here on the top side. But in addition to that, providing resources to help them isolate safely and securely. Next slide. And part of that support for isolation is really important, especially for vulnerable populations. Ensuring that when we ask them to isolate, that they are able to do that without sacrificing their health, without sacrificing their financial situation and their housing. And so part of this project is really supporting them in all of these 6 domains you see listed here. Next slide, please. And so our approach is 2-pronged. So we are working at the sites that I've mentioned before to really increase testing as we've described, but also working with vulnerable, even more so vulnerable groups affiliated with the health centers to do longitudinal surveillance, which we hope will help inform us as to the effectiveness of the vaccines as they're rolled out, but also uptake of some of these more novel strategies. We are bringing the implementation science lens to this work using the RE-AIM framework, Reach, Effectiveness, Adoption, Implementation, and Maintenance to evaluate our work. Next slide, please. And so with RADx Up, we're leveraging the robust infrastructure of ECHORN and the Yale TCC, including its effective multidisciplinary consortium of stakeholders. It gives us really a unique opportunity to focus and highlight the US territories who have been affected by long-standing territorial disparities, providing a unique partnership between federally qualified health centers and local community-based organizations to increase COVID-19 testing, but really ensuring that we're providing those critical domains of support to ensure safe and effective isolation. And providing an opportunity to strengthen capacity of these FQHCs who we know need the resources, but also are really critical in addressing the disparities we're all here to discuss. And with that, I'll thank this amazing team. It truly takes a village. So thanking all of our leaders, our principal investigators, our stakeholders, and our funders. Thank you.
Thank you all the speakers for your wonderful presentations. I think at this point, we'll open it up to the floor for any questions. I do not see any questions on the chat option. Amy, are you on board?
I am. As a reminder, everyone, if you have questions, go ahead and throw those into the chat on the virtual platform.
Okay, so well, there's one question for David from Shanita. Are you incorporating ancestry informative markers into vitamin D work? Minoli, it's possible that David has stepped out. Do you want to answer that question?
So I won't say for sure with the newest initiatives. I do know that in our cohort that we collected the initial susceptibility and hospitalization data in African Americans, we have whole genome genotyping. So it's actually more comprehensive than ancestral informative markers. So you can do actually more in-depth analysis on ancestry and account for the variability in ancestry for African Americans as a population. So there's variability innate in that population, and we always account for that because it's incredibly important, especially in genomic studies. So for everything we do, whether that's pharmacogenomics or for the vitamin D work, we have accounted for that variability.
Okay, so we have a question for the panel. How do you balance the need for diverse inclusion of representative populations in precision medicine research with the risk of biologizing race?
I can start unless someone else would like to start. We are very conscious of our word usage. Actually, I don't use the word race because that while race is a real thing, it's a social construct. And for us in genomics, we use ancestry to understand the biological underpinnings of disease. And so we have spent a lot of time with our stakeholder board talking about the correct usage, as well as running studies on communication and how best to communicate about genomic studies. So we are collaborating with the Department of Communications here at Northwestern around communication to minority populations in collaboration with our community and stakeholder board. So I don't know if that really answers the question, but my answer is that language matters in how you address, very specifically, I think, for genomic studies, which are sensitive for many other reasons, how you talk about race versus ancestry. And so I tend to discuss ancestry.
So let me add another. I think that's a really critical question. And one of my colleagues, Carlos Bustamante, as well as Esteban Burchard, have actually spoken about this quite a bit and written a number of op-eds around the issue of biologizing race. And I do think that genomics are critical. I agree with Manoli that race is a social construct. And but we do need to explore the genetic basis for disease and keeping that race and ethnicity neutral. I mean, we really know that the issues that we are facing now are not only genetic, but they're also social determinants of health. So that is universal. So a social determinant is not specific to one race or an ethnic group. And I think it is critical that that message gets out. And I am concerned, frankly, with COVID that we started this way back when I was a trainee with HIV, starting to categorize individuals by risk based on ethnicity and other groups. And I worry that we're going to go down the same path here because what we're really talking about are determinants of health. For most of these groups, for the vast majority. And I do think there will be genetic markers, as you've heard some of our team members talk about here. But the issue really is not, we can't boil it down to a simple color spectrum here. This is really about health equity, and equity is universal. So that's a great question.
I'd like to answer as well. So the problem is that unless you're a scientist or a researcher with a broad base of training, or you're part of an interdisciplinary group or a multidisciplinary group, you're not going to have a really good handle on any of these issues, because people often mix epidemiological research with basic biomechanistic research. And that's the difference between race-based, ethnic-based, or ancestral-based precision medicine. So Ruha Benjamin often talks how we do not have the technology or the money to do precision medicine well. What we do have is a lack of information and data around what Dr. Maldonado spoke of, which is all the social determinants of health, including ancestry. And so we should be focusing our money towards public health broadly. So that's what we can do right now with COVID and some of these ancestry-based markers. It's not going to be perfect, but it's going to be better than what we've had. So to avoid some of the biologizing of race, we need to make sure that there are researchers of color doing this work in their own communities, because we even see, of course, with the Native American community, there are Mexicans, there are Canadians, there are Native Americans, there are people from Guatemala, Peru, and Chile. They're all different kinds of Native Americans. They have different kinds of admixture with Black and white populations. And you need that context in these kinds of investigations. And with the African American community, you have African Americans from the United States, from the Caribbean, from Brazil, and from continental Africa. Those are all different populations, and you're going to get different answers based on the socioeconomic conditions of those different places. So to do this well, we are not trying to biologize race. We are trying to use the tools that we have to answer questions in the context that Dr. Maldonado spoke of. But you can only do that when the decision makers are from those communities. If they're not from those communities, people gloss over all kinds of issues and just try to make a one-size-fits-all picture. And we don't want to do that.
All right.
Thank you all. We did have
Okay, so I
a few
have a
more
question
questions
for
come
the
in. So
I have a question for the panel. So, so translating some of these initial successes of precision medicine to diverse communities and to a larger scale will obviously require some sort of a coordinated and sustained national effort. And you have to pay careful attention to the broader public health impact. So can you provide your thoughts on how best to prepare or approach future pandemics using precision medicine approaches based on the work in your individual centers?
So I'm happy to start with that. So I didn't have time to go into many of the other investigators here. We're doing a lot of more work, but obviously we wanted to stick to a reasonable time frame today. But much of the work that we're doing around the country and here at Stanford in particular, as well as we're looking at population-based work around COVID. So not just taking convenience samples, but doing population-based work around risk, looking at weighting, for example, based on census tract, based on sociodemographics, trying to understand what patterns we can find from this particular disease. We're looking at genotyping viruses and looking at phylogenetic tracking so that we can understand mutation of this virus. But we're also trying to learn from this virus and extrapolate that to families of viruses that already are in communities around the world so that we can understand what may be coming next. That requires partnerships with our evolutionary biologists, with our climate scientologists, with many other groups. From a social determinant standpoint, I think we need to understand health equity a lot better because clearly we learned where the cracks in our healthcare systems are. We learned that the patchwork approach that we have to healthcare in the US really allowed major groups of people to fall through and not receive adequate care or testing. And I think this is a call to action, frankly, for us to really understand how to beef up our healthcare system. We do have all of us have pandemic preparedness plans. How do we put those into place based on what we've learned now? We learned from H1N1, we learned from Ebola, we've learned from SARS, original SARS. We should learn from this as well on how to structure our healthcare systems as well as our community engagement and our laboratory and field-based trials. So it's pretty comprehensive. I mean, I think just about anything we do today should be a lesson for anybody who's a scholar and a community-based faculty member, teacher, clinician.
This is Shanita. I just want to echo a couple of things that Bonnie pointed out. One of the ways in which I think the precision medicine centers and consortia, one of our key products has been the production, development, evaluation, and ultimately implementation of a diverse set of tools that can be sort of configured into I think, a really effective toolbox to help us think about population health within the context of precision medicine more effectively. Here at MUSC, we've been, as I mentioned, developing ways to add and annotate our clinical data with data relevant for social determinants, either using natural language processing tools, which is an artificial intelligence approach, to using census level data and integrating that information relative to create social deprivation indices and annotating that into the clinical electronic health record. And then as we think sort of downstream, where we want to go next is really adding that sort of data from biospecimens, genomic data, into sort of this multi-level database and data set. And I think that's really, to me, I think one of the key successes of the precision medicine centers is that, we've been thinking about data integration in a very comprehensive, I think very sophisticated way that can be applied in future efforts, as hopefully we'll not have another pandemic, but that as we think about population health and healthcare in general, that the work of our centers can be leveraged to advance those initiatives.
Hi, I'd like to kind of, I guess we're all piggybacking. So I do want to say one of the things that worries me a lot and is, kind of the long-term effects of things like COVID-19, and we don't know what the long-term complications are. We're hearing things, brain fog, all of these different things. And, if we, in 2 or 3 weeks or months, if we say, okay, everyone is appropriately vaccinated and now we're clear, there are going to be so many people who are experiencing these long-term effects. And so the populations that are probably carrying the greatest complication burden are probably the ones who will probably have a lot of these long-term effects that we don't know about. And some of the things that we've been doing with a lot of the precision medicine projects in our collaborative and others are these kind of the work of kind of risk scoring. How can we kind of track people who've tested positive and track them? Maybe there's some way that we can use some of these risk scores to kind of predict some of these long-term effects. But I just concerned that if we don't get on top of that for COVID-19 and any pandemic, these long-term effects, and we're so focused right now, and we do need to get everyone vaccinated, but there's a big concern about kind of these long haulers and these consequences that we're just not even sure about right now. So I think that's one of the ways that we can leverage our precision medicine approaches for this pandemic, and hopefully we won't have any more. So something.
So Dr. Miller, I also want to could you also expand on the importance of community engagement in your efforts to address COVID-19? Because it sort of has this sort of a contextual, geographical, personalized, but at the community level approach that seems to be important. So I was wondering if you could talk a little bit about that.
Yes, it is vitally important. And I think we talked about community engaged research and community involvement all the time. And I think I heard it throughout everyone's presentation. I think this pandemic has really made it clear to all of us that this is really important. I think those people who had networks of people who are already working together, it was a little bit easier to work with those community organizations and stakeholders because there's already some trust built there. And so I think we've kind of been able to benefit from a lot of that, but it is hugely important. And these partnerships are not built overnight. The trust is not built overnight. And so I think if nothing else, I think we've seen how we need to mobilize. And so people who've able to do that quickly, it's been these existing relationships that have really, really mattered. So I think this has really illuminated the importance of what we've been saying, all along, not just in crisis, but this is just really important overall. So I can't state enough how much that is, and not in only the things we've talked about today and kind of developing the solutions. We find something in research, it has to be translated. And sometimes in our academic institutions, we're not in the position to translate this. This might be the community-based organizations. So bringing them on to help kind of develop some of these solutions and rolling out some of our interventions is vitally important.
So I have a question to the panel. How can we encourage people to continue testing as more people are vaccinated?
Well, again, speaking to what Stephanie, Dr. Miller spoke about is, I think one of the things that we've all found out, and of course the theme of this whole conference really is around translating science into action. And one of the ways we've all been able to do that is by reaching out to our communities and providing information to our communities based on the science that we've done. And we are not anywhere near reaching nirvana here. We are still on a path. And I think with, much like the previous question about pandemics, we haven't even really finished this one yet. And daily, I'm just looking at a little note that just showed up about AstraZeneca and some issues that came up around that. And data is popping out every single second. If we can't keep up with it, our communities are not going to be able to keep up either. And it's vital to keep that community-based approach, that clinical translational approach, not only to science and research, but to communicating best medical and social health practices, public health practices in our communities. Because testing is, who knows what testing will look like next week, in a month, in 6 months, we don't know. And if we don't know, our communities are going to be confused as well, especially as you heard one of our colleagues today talk about the fact that predicting ability, English proficiency as a marker poor access and poor testing. We need to continue to reach out to these public populations. And I would say that all of us here are probably spending a lot of our time messaging to our communities. I wouldn't say it's a minority tax, but it is a burden that we take on ourselves. And this again comes back to what Mr. Aracheta said, soon to be Dr. Aracheta said, that we need to continue to bring people to the table who look like the communities, because they're the ones who are going to go into the communities and help them understand the information that is coming out fast and furious. So this is another call to action to keep people, our academic and community workforce engaged with communities of color by being part of those communities of color. And communication is critical. We can never over communicate. It's almost impossible to say that you have over communicated.
Dr. Aracheta, do you want to add any comments about sort of the barriers and implementing some of these testing and vaccination efforts in some of the Native and tribal communities?
Yeah, so things were a little bit backwards for us, as I mentioned earlier, and people felt the social injustice of not having testing here and having such a delay, both in testing and in funding for local. And we did not suffer as badly as the Navajo Reservation did here on the Northern Plains, but we did have, of course, the public fight with the governor of South Dakota, because lots of the reservations put up checkpoints. So people were clamoring for testing, and they still are willing to be tested. They have a little bit of resentment that they had to wait so long, but they're still willing to be tested. The vaccination is going a little bit more slowly here, again, opposite to Navajo. And Navajo is just a bigger tribal community where they have a lot more political clout to get the services that they need. The smaller reservations don't have that kind of clout. And so making sure that the vaccinations and the data around the vaccinations and any kind of follow-up for adverse effects always adds to the mistrust that communities like this have. So the vaccination comfort in Navajo is different than it is here in the Northern Plains. That being said, I think that with the momentum that we have with the testing, I don't think it would be at all slowed with the vaccination, because people here are quite aware of the possibility of variants and the possibility of not reaching herd health, mostly because we have tribal elders and they are the bearers of culture and the only holders of the language, and we really don't want to lose them. So for us, there's an added urgency to get tested and get vaccinated, because we don't want to lose the language or the culture.
Within the last, we have a few minutes left, and I was wondering if any of the panelists have any other comments or anything that you would like to share.
I just wanted to thank Nishadi and the other members of the NIMHD program team for supporting all of us in this important work. It's really a shame that we will be ending, actually tomorrow is our last day of funding. And we're hoping that our group, this is a tremendous group. I learned so much from all of you, and I'm sure we we'll keep working together in different ways, but we really appreciate the NIH support and look forward to future work together, because COVID is just but one problem that we're facing today in our populations, and precision health is really the a really exciting approach for us to start to address health inequities.
Thank you, Bonnie, for those kind words, and definitely we'll find ways to work together, because this is such an important area of research, and I don't think we should stop putting our efforts in this space due to lack of funding for this particular initiative, and I'm sure there will be others to come. So, all right, with that, I think we will conclude our session. So I want to thank all the speakers and the attendees for participating, and if there are any other questions, that you may have for any of the speakers, you are able to contact them. I hope you enjoy the rest of your meeting. Thank you very much, everyone. Bye.